Thank you very much. It's really a pleasure to be here, and thank you for the honor of the kind invitation again. So I'm going to actually show some few cases, but these are my disclosures. This last speaker obviously went through this very nicely, so I'm not going to belabor the point. But it's important to remember that with endarterectomy, there are some issues that's dealing with it after the case. Scarred groins can really make it quite difficult, but obviously it is a very durable procedure. This one particular paper, I think, does give some pause. It's not quite as benign as it sometimes purported to be. In this paper from JVS, it was a 3.4% mortality, which is obviously double what it would be for an endovascular approach. And a lot of those complications occur after the patient has been discharged from the hospital. So there, of course, have been a number of papers looking at the utility of using endovascular approaches. Steve Hale, one of our former fellows, published a nice paper on this a year and a half ago, and the results are all over the place. A lot of the original papers were retrospective. They were primarily PTA, and the rates of stent use vary widely, and the results vary widely, from a 97% two-year freedom from TLR rate in one paper versus 42.5% in another paper. This particular report from the VQI group, again, showed that the complications with endovascular are relatively minor, and that the amputation-free survival, patency, and freedom from TLR rates are really quite good. And not surprisingly, claudicants do better than rest patients, who of course do better than patients who have tissue loss. The TICO trial was actually a randomized trial that of stenting versus endarterectomy in patients with de novo disease. This was performed at 17 centers in France, and they were followed for 2 years. Some of these actually included bare metal stents, balloon expandable. If you look at the primary endpoint, which was perioperative mortality at 30 days, obviously it was in favor of the endovascular group. But then if you look at the secondary outcomes, including freedom from TLR, patency, freedom from target extremity revascularization, and survival, there was really no difference between the two groups. Now, if you are forced to use a stent in a common femoral, Supera is probably the best one to use because you can put a sheath through it. It's very flexible, and it's not laser cut from a single tube of nitinol, but rather 6 interwoven wires, and has a great deal of flexibility and crush resistance. This particular paper from Koen-de-Loos in Europe, again, looking at patients with 85% heavily calcified lesions, and they found that, at least in the short term, 100% primary patency and freedom from TLR with no deaths and no amputations. So I'm actually going to just show you some real live cases. This is probably on the easier side of the spectrum, patient with a relatively isolated focal CFA stenosis with good runoff. And you can see that in this particular case, we elected to use a combination of atherectomy after sizing the vessel with IVUS. We performed directional atherectomy followed by drug-coated balloon, and you can see a very nice acute angiographic result. And a simple procedure, it takes about an hour, hour and a half, patient goes home the same day. This is a little bit more complicated a case with severe disease of the distal SFA with occlusions of both the SFA and the profunda. And in this particular case, we were able to cross that total occlusion into the deep femoral branch of the profunda, performed orbital atherectomy, and then placed an embolic protection device to do some additional debulking, followed by focus force angioplasty, drug-coated balloon, and ultimately ended up with really, I think, a quite nice result. This is a little bit more complicated patient with an occlusion of the SFA itself with severe calcific disease, not only involving the SFA but also the popliteal, but with preserved runoff. And fortunately, we were able to get a wire through here nice and cleanly, placed an embolic protection device, made a channel with orbital atherectomy, followed by excisional atherectomy, PTA, drug-coated balloon, and ultimately we're able to achieve a very nice result with restoration of 3-vessel runoff to the foot. So let me just show you another case of a patient who had very, very extensive disease, who had an occlusion not only of the SFA but also the popliteal. And this was a patient who had a small plantar ulcer but was very frail and elderly. And so our thinking was that if we could just open up the inflow into that large profunda, that might be enough. So we performed intravascular ultrasound. You can see here a pretty densely calcified lesion there at the CFA profunda bifurcation. First made a channel with orbital atherectomy, and then after IVUS, you can see considerable debulking. And this was followed up with intravascular lithotripsy, which I feel is really, for calcific common femoral disease, really the mainstay of therapy and has been for those patients in whom we choose to treat with an endovascular approach. And then followed by additional cutting balloon angioplasty, and then the IVUS image really tells the tale. We're able to achieve very nice debulking in this particular patient. There's another patient with a distal SFA occlusion with a lateral plantar ulcer. Again, used a combination of atherectomy with lithotripsy, and we're able to debulk that, followed up with DCB, and then went down and took care of that distal SFA disease with lithotripsy, and followed by drug-coated balloon. But he still had poor outflow. And again, this was a patient with a ulcer, so we went ahead and took care of that by dilating the outflow. But ultimately, we're able to restore direct inline flow to the foot, and he successfully healed his ulcer. This is really an interesting case of a gentleman who had horrific bilateral calcific disease, dense calcification of the common femoral. You can see that his common femoral basically ends in these two large collaterals with reconstitution there proximally. Super calcified, but not too terribly diseased distally. So the question is, how do you cross a lesion like this? Well, we elected to do this with an ultrasound-guided direct anterior thigh SFA stick. And this is what it looked like, and basically just placed a micropuncture sheath in there, and then used a front runner to get through that severe calcific disease retrograde. Once we're in the true lumen, snared that wire, exteriorized it, and sent it down the other way. Placed an embo shield, followed by orbital atherectomy, intravascular lithotripsy, and really were able to get a terrific result. And then with adjunctive drug-coated balloon, we're able to get a great result. He then returned to the lab to treat the other leg, which was even worse. And as you can see, just horrific disease there. Multi-level occlusions of the SFA and popliteal. We're fortunately able to get down into that anterior tibial, which was his primary runoff vessel to the foot, treated that with laser, and then adjunctive intravascular lithotripsy with a 5mm device in the popliteal, followed by drug-coated balloon, a 6mm device for the SFA, 6.5 proximally, and ultimately a 7mm device that was used for the common femoral. And you can see that after adjunctive drug-coated balloon angioplasty, we did place a stent, a superior stent for that distal disease, and we're able to achieve opening of that profunda lesion as well. And ultimately, we're able to get a terrific result, as you'll see here, with restoration of inline flow to the foot. So in conclusion, while common femoral endarterectomy may still be the gold standard for CFA disease, it does carry morbidity that we have to be aware of. And endovascular therapy for CFA disease is favored for those patients who are not good candidates for endarterectomy. We have to admit, though, that it may require more interventions. Stenting is safe and feasible and non-inferior in this one small randomized French trial, but I think most of us agree that atherectomy and DCB are favored to leave nothing behind. And in our experience, we've definitely found that intravascular lithotripsy is a very important and valuable adjunct to treating these patients. Thanks very much.
Thank you.
So we're running a little bit late, but we'll do a little bit of a panel. Any questions from the audience? So a quick question for the vascular surgeons and the cardiologists in the panel. When do you refer that common femoral disease, if you're a vascular surgeon for endovascular, or if you're a cardiologist for surgery?
So I would do endovascular in the common femoral in somebody who's not a surgical candidate, somebody who's very high risk, and I would do everything possible not to put a stent in, because once you put the stent in, let's just forget what we found in our paper from the VQI, that increases the risk of reinterventions and increases the risk of amputations. Once you put the stent in, you can't really go back. If you have to go back into that groin, it becomes almost impossible. And so you basically, you can do that if somebody has a very low life expectancy.
You know, I think for us, you know, we're very patient specific, just like, and I echo everything he said, you know, people with high surgical risk who have very reasonable targets. I mean, he showed some very complicated lesions with excellent results. So, you know, it can definitely be done, but for the very heavily densely calcified popcorn lesions with profunded disease, we tend to still send those for surgery.
In the next minute, what I want to highlight, looking at Peter's cases, there are three things that I think are interesting. Number one, Peter can do both endovascular and surgical. So a big question is that should those be the guys should tackle as the common femoral? Second, if you notice very carefully, and I hope we all did, the case selections were immaculate. They were either a compelling clinical indication or anatomical favorable factors that he chose very carefully, i.e. the location of the lesion, the focality, the calcification, and also the patency of the profunda and the origin. So I'm going to use it as a linchpin and say, is there any harm that while you're doing an iliac intervention, you find a disease common femoral and you gently balloon it versus going a priori in a claudicant with a common femoral disease. So I'm going to get some opinions from the panel. I'm going to ask my friend Dr. Mehdi Shishabur how he plans and what does he suggest for young peripheral interventionalists who are going to take up this field and how should they approach the common femoral artery for a claudicant?
I think this area creates a lot of controversy, and if you're a young operator, politically, I think it's a good idea to have a discussion with your vascular surgeon in your institution to come up with a plan. You'd be surprised, in many cases, they actually will encourage you. As a matter of fact, even myself, a couple of patients that I have referred, I was yelled at by one of my surgical colleagues that why the heck did you send this for surgery? Because one of the patients ended up with groin infection and actually died from groin infection. So my point of it is that if you're early on in your career, make sure you build relationships and discuss it. And if ends up endarterectomy is the best approach, then go for it. If it's not, then you can maybe work together, or if you feel confident, do it yourself. I think the one thing that we should emphasize is that there is alternative approaches. There is no such a thing that is only surgical, because I know that when I was training, I was told that common femoral popliteal, you never touch. And that's a complete myth. And I remember one time when I treated a popliteal artery many years ago, somebody told me, oh, you put a stent. And my comment was that, please give me 20 stents, but don't cut my leg. So if you can save a patient's leg when there are no surgical options, make sure you know there are other options available.
Great, and that's a great saga for what is the role for intervention in this particular segment in CLI. There's any difference between claudication and CLI in the therapeutic approaches, outflow at the same time, stratifying, or maybe a hybrid approach? What are the panel opinions on that?
I think for claudication, you need to find the most durable approach you can. I think we have all these tools. We have surgical tools, endovascular tools, a combination of the two. And in treating claudicants, we need to do everything possible to give them the most durable repair, because that's sort of the whole point behind it. They have a longer life expectancy, and you want to give them something that's durable.
Art, how do you approach? Again, I want to specify the scenario in a setting of a claudication. So you do an angiogram, and I think we want to hear your take on it, and what do you advise people who are taking this field on as budding peripheral interventionalists?
Yeah, I think as budding peripheral interventionalist, I agree completely with Mehdi. I can tell you that, common femoral, I'm very quick to send to surgery. I've, profunda status and also body habitus. If they have a big belly, they're pretty big people, I tend to do more endovascular just because I've seen some really bad wound infections with that. But even if they're not a surgical candidate, it's a separate issue. But if they're a good surgical candidate, I find myself sometimes trying to talk them into surgery. Honestly, they want us to just fix it, and sometimes it just depends on the profunda, body habitus, and the discussion with the patient. If they know that they might have to come back, I'm fairly comfortable usually seeing the lesion, knowing if I'm going to have to put a stent or not. And I think most of the time with lithoplasty and all the technologies we have today, that we can get away without having to put a metal implant in there.